Dear viewers interested in sleep medicine, dear friends of our show, Sleep Lab with Netzer and Popovic, today we've reached what will be our final episode for now. Of course, we hope to get another season and that you'll tune in again. But today we're going to talk once more about the important topic of sleep apnea, how to diagnose sleep apnea and how to treat it.
A warm welcome from me as well. And Nikki, I'd like to start by asking you the first question. What exactly is involved in a case of sleep apnea?
Yes, I'm often asked why some people have sleep apnea and why others don't. And I'd like to demonstrate that now using this model here. I hope you can see it clearly. So what we have here is the pharynx or throat. And this would be its state during the day. And during the day, of course, as everyone knows, we can breathe quite well. So here, I hope you can see it. The air passes through here, through the nose or the mouth. It goes past the uvula and then down. Now, a lot of people think that up here at the uvula or the soft palate, that this is where they snore and that this is where the biggest problem lies, so to speak. But that's not the case. Now I'll show you on this model what happens at night when the musculature more or less relaxes during the night and the tongue, this is the tongue here, falls back a little. Then you can see, let's look here again. You can see exactly where the narrowest point is. It's right here, specifically above the epiglottis. This is where it gets narrowest, and this is essentially where snoring begins. If it then becomes so narrow that no air can get through at all through this small opening here, then we're talking about a complete cessation of breathing or an apnea. But I'm going to demonstrate this for you one more time. And let's take a look at the whole thing. For this, we need a little bit of physics. Hagen-Poiseuille's law or Bernoulli's principle, you don't really need to worry about that now. Instead, just imagine a large river. We live near the Inn River here, and imagine this large, wide river suddenly becomes narrow. What forms then? Of course, eddies or rapids. Okay, and now let's apply this. For that, we actually only need 2 sheets of paper. You can demonstrate this to anyone to show how it works. This is essentially our throat, more or less, or the banks of your river, however you want to think of it. And we can now just see the air passes through quite easily. That's the case during the day, but now come our rapids. This would be, so to speak, what happens at night when the walls of the throat relax and the tongue relaxes and the whole thing becomes significantly narrower. And then it looks like this. Yes, and you see a sound is immediately created. That's caused by the turbulence. Here in this case with the air, on the river, it would of course be the water that becomes turbulent and creates a whirlpool. Yes, okay. But now, of course, I've blown air out. You have to imagine this in reverse, of course. It's not about blowing out, but of course, this whirlpool, this turbulence is created when you inhale because you have a strong suction then. So inhaling, yes. And then if I inhale even more forcefully, it can happen that the walls are completely together and no more air gets through. Pause. Yes? Let's look at this whole thing again on the model here, and I'm going to show this again. So as I said, we now have this model. Why do some people have sleep apnea and why don't others? And you can see on this model now, so to speak, that no more air gets through here. The whole thing is basically a mechanical problem. So here, yes, no more air gets through, and you can also see where it is. Down there, as I said, just before the epiglottis. That's the narrowest point, and not up at the uvula or the soft palate. That has something to do with anatomy, of course. You can see that the jaw plays a role here. The size of the tongue plays a role, and as I said, how large and sometimes even how muscular the pharyngeal walls are. Yes? Now that alone explains almost everything. That is the anatomy, but not completely. So there are other factors, and Reiner has also done research on this topic back in Denver. Gender plays a role, age plays a role, and what's especially important is how strong the respiratory drive is. So under certain circumstances, also how deeply one inhales and exhales. And when a young person inhales, they inhale very deeply. An older person maybe only, yes, and a woman, she has a big advantage because her pharyngeal walls are tense even at night, and what helps them then are the female sex hormones, progesterone. Or what do you think? After all, you've done research on this topic.
Progesterone helps, that's absolutely correct. But now comes the twist, yes? The moment women enter postmenopause, this hormone naturally drops, and then they are on equal footing with men when it comes to snoring.
Post or perimenopause, because I've heard it also happens in perimenopause.
Back in my day, when I researched this, we purely investigated postmenopausal women. That means I can confirm that. I didn't investigate perimenopausal.
But as I said, again, you agree with me, it's more complicated than just anatomy. That's why purely anatomical examinations haven't gotten us any further. And it is a bit more complicated, isn't it?
On the contrary, we used to lack the explanations when we only considered anatomy. But you have to add the complexity of respiratory control. And that includes, among other things, sensitivity, meaning how a person reacts to an increase in the CO2 level in the blood during a pause in breathing. With every pause in breathing, the CO2 level rises. One person starts panting quickly, another takes a long time. And putting all these complex regulatory processes together is what gives you the whole picture.
Yes, that might explain to you a little bit why one person gets sleep apnea and another doesn't, even though both snore. So Rainer and I have to admit, at our age, you can do the math. We've been in the profession for 40 years. Yes, so neither of us will spend every night completely without snoring. But that doesn't mean you necessarily get sleep apnea. But those who do get sleep apnea, they have a major problem with their health. Rainer, perhaps you could tell us what the biggest problems are?
So briefly again, on the subject of having sleep apnea or not, it should be pointed out that it always depends on the severity of the sleep apnea. That is a mild, a moderate, a severe sleep apnea. All of this is relevant when we consider whether a patient with their symptoms requires or is a candidate for therapy or not. And depending on where you draw the line and say this is still normal or this is no longer normal, they may or must be treated or not. So that, so to speak, is the art, the medical art of saying one patient is still below this threshold and the other patient is already over this threshold and may also have risk factors like having already had a heart attack or having already had a stroke. And the sum of these risk factors must also be taken into account when considering the necessity of therapy.
But you'd agree that people with severe sleep apnea, so snoring sound, pause, and so on, they are at a higher risk for a stroke and for diabetes. And of course, and I think this is the most important thing, is the daytime sleepiness. So you're not fully alert when driving, and there are countless examples of accidents caused by sleep apnea. The most famous accidents involving ships, trains, airplanes, buses, and so on, as our viewers probably already know from the news.
So one needs to briefly explain what happens during these processes, or in summary, the longer such an anomaly persists.
Yes, I'll demonstrate that again briefly for you. Ultimately, if someone has apnea, for example, or for instance, then there is a signal after a certain period of time that the body no longer receives oxygen. This signal is processed by the brain, and the brain sends a message to the adrenal gland. And this adrenal gland suddenly releases adrenaline into the body. It would be roughly the same as if someone suddenly stabbed you in the arm with a knife. And then this happens. Pause, and suddenly, does breathing resume? We call that aerosol. And this reaction, this is what causes the many problems that sleep apnea causes. And so that we can take a closer look at this, let's take another look. The sleep lab in Bolzano is now examining precisely what effects these pauses have on the EEG and on sleep. So Heikki, now we have a breathing pattern that is no longer ideal. Perhaps you can explain to us, with regard to the patients, what stage 2 sleep we see here. And I believe this is also more common in REM and light sleep phases, which is what's wrong with the breathing here.
We just had a consistently beautiful breathing profile here. And if you look closely now, I'll make this a little bigger. Here. He takes 3 breaths and then pauses. For example, in this case, 20 seconds, or in this case, 27 seconds. And what we can observe very, very clearly is that these opposing breathing movements can be seen here. This means that the upper neck area is closed and the thorax and abdomen are moving in opposite directions. The consequences of such an apnea can be observed here. An oxygen desaturation of 16%. This means that the patient falls asleep, always very briefly, and then experiences apnea. At some point, the brain screams, "Help, help, I'm not getting enough oxygen." And as you can see very clearly here in this particular example, breathing resumes with a loud, unmistakable snore. He sometimes even hyperventilates, taking in rapid, shallow breaths, only to fall asleep once again and have another episode of apnea, where his breathing stops temporarily. What you see here is the pulse, and you see artifacts here. Here too it is clear, he wakes up, moves, and that naturally results in artifacts on the oxygen sensor.
We also see, and I think this is not uninteresting for people with a certain delay here, that the pulse rate drops during apnea. The lower the pulse goes. Do you know why that is?
Because he's under stress, or he's recovering during this short sleep phase where he's having his apnea.
Yes, not quite right. So you have to imagine you're a whale.
Okay.
You hold your breath for a very long time.
Okay.
Then your pulse goes down. You're right, so that the heart can recover, so that it doesn't need so much oxygen. And this so-called diving reflex is still inside us. We have it from a time, I don't know, millions of years ago, and that's what causes the pulse to practically drop. So as soon as we have a respiratory arrest here for a longer period, our pulse goes down because the heart is now trying to get by with less oxygen.
Okay.
And then it goes back up again.
Because we're under stress, right? The body is under real stress after an apnea like that. It really is.
And that is the great danger here at this point for a possible stroke or heart attack, which can be caused by the apneas, because this is also such a sensitive phase for the heart.
Yes, absolutely. And when you see how he desaturates here, right, with a drop of 16% down to 73 here, that is really, really stressful for the body.
What would you say? There are different definitions, a drop of 4% in desaturations or from 3%. Which do you lean towards?
Honestly, in this case, it doesn't matter at all.
It's irrelevant, but I would say, to be on the safe side, I'm more convinced by the 4% than the 3%. But as I said, computers nowadays usually do it from 3%.
You can adjust it. So yes, if you also have the arousal, the sleep stage, you can vary it a bit. When you see that something is really happening with the breathing, right? Something is there, and you see these very regular arousals, these waking reactions, you can also take that into account, you know? And then whether it's 3 or 4%, well, all right, I'll take 3.
So if we look at our sleep profile up there with the breathing, we see something interesting.
Mm-hmm.
Exactly. What do we have now? Now we have no more deep sleep and only very little REM.
Yes.
And that's typical, and of course that's no longer restful sleep.
Mm-hmm. That's right.
Yes. Maybe you have another phase for this patient where the apneas aren't quite so extreme.
This patient, unfortunately, really only has apneas, but we can at least demonstrate another type of apnea, and that's these here.
Oh.
Mm-hmm. How do you like these?
They look great.
Wait, I have another one here. Well, this one isn't quite as nice as these here.
Let's stay on that one. That's also typical for, yes, N2, that's right in REM. Yes, that one, exactly. Here we see a phase where the chest and abdomen are no longer breathing. So that means the attempt to breathe only starts again later. And we call that mixed apnea because it's practically a mixture of a central apnea where there's basically no respiratory drive and an obstructive apnea.
But the explanation for why that is, I think that's quite interesting for the viewers too.
Why that is? Yes, well, that's where it gets complicated, of course, but we can touch on it briefly. A patient like this one who has been used to high carbon dioxide levels for a very long time because he breathes so little, you see, for him, the respiratory drive is reduced. Because carbon dioxide here at the sensor, basically at the chemoreceptor on the carotid artery, that's our measuring probe. And when the patient has been used to high carbon dioxide levels for a very long time, then his respiratory drive kicks in too late. Because that's a sign for patients who have had very severe sleep apnea for a very, very long time.
But that's an interesting clue, isn't it? When you see something like that, you know that he's really had this for a long time and has almost adapted to his situation, in terms of breathing.
With this patient, we haven't heard such strong snoring, so we'll probably have to look at another patient for that, right?
He does have very strong snoring.
Yes, but I mean just snoring with hypopneas, which we can't really...
No, not with this one. The findings are just too pronounced.
Then we'll have to look at our other patient again.
Okay.
So now we're seeing a different picture with the breathing here, different from what we just saw before with those severe apneas. Instead, this is a somewhat milder picture. Perhaps you can describe it for us in more detail.
What you see here are hypopneas. Hypo, too little, pneas, breathing. That means the breathing doesn't stop completely. Instead, there are still breaths. Yes, how should I put it? Breaths being taken, but they aren't sufficient.
And how is that defined then?
Yes, it's a 30% reduction
from the typical normal breathing curve,
followed either by a drop in oxygen or a so-called arousal reaction, an arousal. And whether it's an apnea or a hypopnea, the consequences are actually the same. Because of this desaturation and this arousal reaction, the sleep is fragmented just the same as if it were an apnea. Of course, the strain on the body is perhaps a little less with a hypopnea, Yes, I mean, the depth of the desaturation and the length of the event also play a role.
But it's also harder, I think, to diagnose sometimes. You can easily recognize the severe sleep apnea syndromes. For hypopneas, you really have to do a complete polysomnography. That's perhaps another important point to emphasize why a sleep lab is needed in the first place. Now, with this patient, we see, rather light snoring, but these hypopneas, I believe, they also often occur in heavy snorers, right?
Absolutely. If we weren't being filmed right now, I could demonstrate it very well. What that sounds like, when everything here is just closed up and the effort to breathe is simply immense, with noises too, and you can see that here in the snoring.
Exactly. The effort is sometimes even more extreme than with obstructive apneas. And that's why a professor who has unfortunately passed away, a great professor of sleep medicine, Professor Guilleminot, described this as upper airway resistance syndrome. So you're practically breathing against a resistance, and that's also very strenuous.
Exactly, UARS, correct.
UARS.
Exactly.
So Heike, now you also attached electrodes to the legs of our model. And now let's take a quick look at that as well in a patient with such periodic leg movements. What do we see there?
We see that at a certain interval, the legs move, they twitch, right? That's called PLM, periodic limb movements, as opposed to LM, which can happen from time to time, just twitching your legs. But when it happens at truly regular intervals, there are very precisely defined criteria for when you can call it that. The computer, thank God, can also calculate that all by itself, whether the interval is sufficient and whether the count is sufficient. Because if you had to recalculate that every time, you'd be busy for quite a while. And these leg movements can be an indication of restless leg syndrome.
In this case, however, I don't think so with this patient, because if we look closely, we have the flow curve running at the top, and these leg movements always appear when breathing suddenly becomes stronger again, during hypopneas, by the way, just as we saw earlier.
What you also see is that these leg movements don't produce an arousal up here, right? There is a short interruption here, aber das ist ein Artefakt, ne? This twitching causes a very brief interruption in the recording, which is called an artifact, a small disturbance. And for some people, it doesn't matter at all. Some people twitch their legs all night and don't even notice it, only when it really becomes a restless leg syndrome.
But when something like that is treated, then in my experience, these periodic leg movements, which come with respiratory arousals, that is, an awakening reaction after an apnea, or in this case, a hypopnea, they also go away, which in turn leads to the patients feeling even more rested because they no longer have cramps from these leg movements. And so that's another aspect that's important for the treatment of sleep apnea, or what we have in this case, a sleep apnea hypopnea syndrome.
Conversely, it can of course also be a case of unmasking, right? Where you unmask a restless leg syndrome by treating the respiratory.
That's why it's important that we still have the leg electrodes on when we then treat with CPAP and can then see that again.
Exactly.
All right, we're back from the sleep lab in Bolzano. Now for a few more relevant points concerning therapy. But before that, I'd like to briefly mention one of the main problems of obstructive sleep apnea. As Nikki already mentioned, these arousals lead to disturbed sleep. And disturbed sleep means that the next day, even though we've spent 7, 8, or 9 hours in bed sleeping, that sleep wasn't actually restful, and this results in daytime sleepiness. This is where, for example, we see more car accidents due to microsleep, where excavator operators doze off on the job when the excavator runs over a colleague. So very dangerous accidents can occur because of this daytime sleepiness. And this daytime sleepiness is one of the key factors indicating that sleep apnea must be treated. And the second issue is also, as Nikki explained so well, that in this stress situation where adrenaline is released, the heart reacts extremely with an increased heart rate, and that of course puts a strain on the heart and circulatory system. And over time, these strains lead to cardiovascular diseases such as stroke, high blood pressure, or heart attack. And the daytime sleepiness, combined with these diseases that sleep apnea entails, is the factor that allows us, as doctors, so to speak, to determine which patient is a candidate for therapy and which is not. And that brings us to the topic of sleep apnea therapy. Perhaps you can say a few words about the most common forms of therapy for obstructive sleep apnea.
Yes, in principle, we classically have 2 forms of therapy that have been around for some time now and are also generally covered by statutory health insurance. The best known one, many of you will be familiar with this therapy, is because you often see it or you have an acquaintance, a friend, or a colleague who has a so-called CPAP machine. And this CPAP machine, we've set one up here. And I actually wanted to ask Rainer if he would put the mask on for me, but he said, nah, I'd rather not. I might make a mistake and put the mask on backwards. And so I'll put the mask on myself now. Don't forget to take off the glasses. Now you'll hear my voice sound a bit different, but that's not a big deal. You can see the mouth remains free. It's just a nasal mask. And Rainer, you're signaling to me I'm not a fan of full face masks, but rather just nasal masks. In any case, let's turn on the machine.
And the difference, I'd like to explain that. In this case, we're only using a nasal mask, where the mouth can theoretically stay open, which can interfere with the therapy. Or we use a full face mask that goes over both the nose and mouth. It seals better, serves both openings, so to speak, and is safer for this type of therapy, but maybe a little more uncomfortable.
Yeah, I have a bit of a different opinion on that. I don't like those things. But as I said, you can hear it now. The machine is running. You can also tell because my voice has changed a bit, though not quite Mickey Mouse-like yet. We're now at the usual pressure, which is around 8 millibars. Just imagine it's like sucking up 8 centimeters of water from a glass through a straw about the thickness of your little finger. That's the pressure. So it's no worse than a slightly stiffer breeze at the sea. And as you can hear, you hear nothing. And you can also see from the size of the device, it's no problem. There are batteries, so you can take it with you anywhere. So what's happening here?
Before you continue with your wonderful explanations, I'm going to ask you to take the mask off again. We can really hear you better.
All right, I'll do that right away and turn the machine off. Okay, so I've turned the machine off again, but I want to show you how this all works. And we can see that here on the model. I've turned the model around now, so you're seeing the backside. We're essentially pumping air in through this path, normal air. The CPAP doesn't supply oxygen, as some people believe, just air. And with that air, we're basically pushing this whole thing open. And that allows air to flow through here again. And as I mentioned before, the amount of pressure involved here is really no greater than if you were to try to suck up about 8 centimeters of water from a glass using a straw that is approximately 1 centimeter thick. So it's just like a stiff breeze. That's the simple function of a CPAP machine like this. And it has to be said, yes, it's the most proven therapy. It works every time, consistently, at any time. And it's also by far the most affordable therapy. You have to say that too. So it always works and it's the most affordable. But now I'll get to an alternative that we use especially for people who snore heavily, maybe also have some pauses in breathing, but who don't really have what you'd call severe sleep apnea. Here there's also the option of a custom-fitted dental splint. You can see it. It looks like a normal, I can't get it open right now, a normal dental splint. Yes, that goes over the teeth. In this case, with this model, the whole thing is hooked in here. And what happens now is that the lower jaw is pushed a bit further forward. Let me explain that again with the model. Now I'm back on the other side. You have the tongue here again, yes, and the throat, yes. And now with this splint, I would pull the lower jaw. Come on, I have to close it. Pull it forward. And now you can see a sufficiently large space remains open, so to speak, to get the air through here. That's how the dental splint works. There are other models as well. Here's another model. Yes, here you can see it's connected by a rail like this. Yes, so the important thing is that the lower jaw is pulled slightly forward relative to the upper jaw. These are the most common therapies. And Rainer will now explain what other therapies we have.
If I may just add something and mention the goal of these therapies you've shown so well. The principle is always about a narrowed airway, which, due to relaxing muscles that are supposed to keep the airway open, gets narrower and narrower until it completely collapses, leading to a cessation of breathing. So the primary goal of these therapies is, of course, to widen the airways. On one hand, as just explained, by advancing the lower jaw, which widens the airway.
Rainer, I can quickly demonstrate that for our viewers. It's very simple. You can try this yourself again, just like with the piece of paper before. You can try this. So you would be snoring now. And now you move the lower jaw slightly forward. In medical terminology, this is called the S-mark maneuver. And you see, the further I push it forward, snoring is no longer possible.
That's exactly the principle. And that brings me, aside from the CPAP, which works on the same principle of widening the airway, mechanically with an air cushion, more or less, to another form of therapy. This is for when there is excess tissue in the airway area. And here I'm talking mainly about children or adolescents who have enlarged tonsils. Sometimes they are so large that the airway is almost completely blocked. And here, of course, a very efficient form of therapy is the removal of these oversized tonsils or other tissue parts like an oversized uvula and so on. That's also a surgical consideration.
But it's rarer, and it must be said it's really more applicable to children now. The trend that was fashionable for a while, just lasering everything away, I believe, well, I'm not a fan of it. I don't know how you see it, but it didn't really help a lot of people, except for what we always tell the patients in the sleep lab.
You have to look at that a bit differently. Why a scalpel and why a laser? I don't want to suggest that the doctor earns more with multiple laser sessions. Let's leave that aside entirely. However, with multiple sessions where you only ever remove parts and never too much, because the steps are so varied, you can gradually approach the desired result. That's the advantage of the laser. However, with a tonsillectomy performed with a scalpel, I can position the borders and the suture, so to speak, very precisely, which then leads to a better result through scarring. So there are pros and cons to both methods. But as you rightly say, there are now so many forms of therapy that some of the previously common ones, like what's called UPPP in medical jargon, have more or less faded into the background today. And that brings us to another surgical method. Yes.
No, yes, I was just about to say, you obviously have a lot of trust in our ENT colleagues, but they tend to lean towards a different therapy.
And this therapy is in the hands of our ENT colleagues. With it, we can, so to speak, support the weakness in the control of airway dilation. So when a muscle is supposed to get the command to open the airway, an operation can help with that. We call this hypoglossal nerve stimulation. This means that the nerve that moves the tongue is, so to speak, now stimulated by an amplifier. It's like a pacemaker for the heart, yes. Here, the tongue muscle is given an impulse, either synchronized with the patient's breathing cycle or automatically and repetitively. And this impulse causes the tongue to move forward. So it's the same old principle. We have to widen the airway. Of course, this requires a surgical procedure, which isn't necessarily something to be taken lightly. But ultimately, if a patient, for example, cannot tolerate the CPAP method but needs therapy, this would certainly be a good alternative. Yes, we have.
Because I'll interrupt you for a moment and we'll briefly show a little graphic for this now, where you can see it again. Here on the graphic, you can see this pacemaker depicted.
And regarding the pacemaker, it should be said, so that this method, so to speak, doesn't get a bad reputation, you have to do some preliminary examinations, which are carried out by an ENT doctor or an ENT department in a hospital. During this examination, for example, you are put into a light sleep. And then using an endoscope, you observe how the airway changes during this short sleep phase. You see whether there's a concentric change or a narrowing from side to side or from front to back. And that is crucial in determining whether the subsequent operation will be successful or not. This means operating blindly, implanting the pacemaker. After all, you're essentially creating one or at least two wounds. You're implanting a foreign electronic device. So a proper indication is required, which is ensured by these specialized ENT centers. It's not something that should or can be done quickly just anywhere. It's important that the patient population receiving this form of therapy is very specifically selected, and then you can also expect success. The major disadvantage for us in Austria is that this operation, for example, is unfortunately not covered by health insurance. And here we're talking about sums in the range of 20 to 30,000 euros. If you're lucky enough to be offered this form of therapy as a guinea pig, so to speak, and you're convinced that it's also feasible for you personally, then you should go for it. But considering whether to invest 20 or 30,000 euros, yes, when it might not be quite as effective, is always worth thinking about. But now that we've discussed these major forms of therapy, CPAP, surgery, and so on, I'd like to remind you that there are also certain forms of sleep apnea where, for example, a problem only occurs when lying on your back. Why only when lying on the back? Because in these people, the tongue falls back particularly far and closes the airway. And if these people are encouraged with aids like a pillow behind their back and so on to only sleep on their side, these breathing pauses no longer occur. And the second form, in many cases, especially when overweight is a factor, is to reduce weight. Why?
Yes, I'd like to interrupt you there for a moment. You know, there are people now who say that with the new weight loss shots, not anti-weight loss, I mean the weight loss shots, that you can have such significant weight loss that no sleep apnea therapy is needed anymore. But I believe, based on my experience, we can't give people that much hope. There are some cases where weight loss helps, but certainly not all, especially not with severe sleep apnea. That's my experience anyway.
Of course, there are pros and cons here. And here too, you have to select a specific patient group and determine whether success can be expected or not. But what is also being heavily researched right now are side effects that occur outside of the weight loss itself. And those are interesting to follow. And until then, until we know more, we'll be able to make a better decision about that.
Weight loss, there's another option for weight loss. We've heard several lectures about it, especially at conferences. It would be a surgical intervention for weight loss. What do you think about that?
In this area too, there were surgical methods that are now frowned upon. So you have to be careful about what kind of surgery is performed. But in principle, by reducing the stomach, which is partially resected, so to speak, the feeling of hunger is reduced, and with it, the amount you can eat and digest. But you really have to keep in mind that these people must adopt different eating habits afterwards. So it's not that you just have success without making any changes. You actually have to make a change in your dietary patterns.
Yes, well, that applies to all weight loss methods. We should be clear about that. Perhaps some positive news for those streaming from Germany. Our sleep lab with Netzer and Popovic is in Germany, and the health insurance there, I must say, is really generous. Both the therapy with the hypoglossal nerve stimulator and the therapy with the dental splint are covered by the statutory health insurance in Germany. This is not the case for Austria, it's not the case for Italy, and it's not the case for Switzerland. But in Germany, all forms of sleep apnea treatment are covered by health insurance, though of course it's always dependent on the coordination and decision of the doctors and the medical service of the health insurance funds.
And that also explains why in America more than 20,000 patients have already undergone this operation, while in Austria we have a number that's barely in the low double digits. It's very clear.
Yes. To conclude our final episode here, I'd like to point out that you can, of course, get more information either by contacting us directly or by contacting the German Association of Sleep Medicine, which supports the show. And it should also be said that there are new guidelines, for example, for follow-up care with CPAP, what you should do. Because it's important that if you start a therapy, and therapies are absolutely vital for severe sleep apnea patients, then you should also stick with it. Otherwise, it's all for nothing.
I believe that with our 8 episodes that we've filmed so far, we've brought some very good knowledge to the general public so that it might now be easier to make decisions to go to the doctor and get checked out, or to accept and follow through with a form of therapy. And we're excited to see if there's any feedback. And if the feedback is positive, we'll also try to create more episodes.
Exactly. That's our goal, so to speak, to produce more seasons. Then we also want to go into more detail on other conditions, not just sleep apnea, but narcolepsy, restless legs, REM sleep, behavior disorder. Yes, that's when you suddenly do things in a dream that you really shouldn't be doing. Yeah, so we want to discuss all of that. If there are more episodes, we're counting on you to click on them often. So stream the shows and please recommend them to others. And in that spirit, I'd like to say for now, goodbye, everyone.
And sweet dreams.